First on the agenda, we're going to approve the minutes from February 13th. I will entertain that motion. Representative Neighbor.
Thank you, Mr. Chairman. I move the approval of the minutes for February 13th.
All right, second by Representative Penn. All those in favor say aye.
Aye.
Opposed, say nay. Very good. Minutes are approved. Also, before we get started with what I guess is a kind of a popular deal, today I want to also take final action on HB 2325. Committee, you'll recall that had to deal with the adding maternity center to the definition of healthcare provider. And Eileen, would you like to give us a little, if you'd like to provide more than a balloon? Of course, you may pass out a balloon. Well, we'll shoot those down. That's what we're doing now, you know. We shoot those down on site. Even
the $500,000 missile?
Exactly. Nina was unavailable for comment. Whenever you're ready, Eileen.
I am ready, sir. Thank you, Mr. Chair. House Bill 2325 would add maternity center to the definition of healthcare provider for purposes of the Healthcare Provider Insurance Availability Act. When I originally drafted this bill, I was asked to replicate the budget proviso that had occurred last year. However, in the mix, we received a request to change an or to an and. So this is the balloon that you see on the second page. If you flip it, it would make a maternity center if such maternity center has been granted accreditation by the Commission for Accreditation of Birth Centers, and if such maternity center is a maternity center as defined in KSA 65-503. So essentially, a maternity center would only qualify as a healthcare provider for purposes of the act if it satisfied both conditions, that it meets the definition of maternity center in 65-503 and has been accredited by the Commission for Accreditation of Birth Centers. And I can stand for questions.
All right, questions for Eileen regarding the extensive changes included in this amendment? Seeing none, I would entertain a motion.
Thank you, Mr. Chair. Thank you, Mr. Chair. I'd move this amendment. This was an agreement. You know, this whole bill is an agreement, a negotiated kind of piece of legislation between the maternity center that we heard from last week and the Healthcare Stabilization Fund, and it's very narrowly tailored to accredited maternity centers that also meet the definition. And so I think in able to honor that agreement, I'd move this amendment.
All right, do I have a second? Second by Representative Dodson. All those, well, I guess, discussion. Is there discussion on the amendment? Or change to an and, or and change, yes, or change to an and. That's the crux of it. No discussion? Okay. All right, then. I would now entertain a motion to pass out 2325. Oh, you're right, you're right. There's no discussion on it. All right, all those in favor of the amendment? Yes, Representative Bergquist.
Do you want Representative Proctor to close?
We could do that. Representative Proctor, would you like to close on your amendment?
I close, Mr. Chair.
Very good. You've heard the amendment. All those in favor say aye.
Aye.
Opposed, say nay. Very good. All right, the amendment is adopted. Any further discussion or amendments to 2325? Okay. Seeing none, I would entertain a motion to pass out 2325 favorably as amended. Representative Proctor.
Thank you, Mr. Chair. I move that the committee approve House Bill 2325 as amended, favorable for action.
Excellent. You've heard the motion. Representative Underhill is second. All those in favor say aye. Aye. Opposed, say nay. Very good, committee. We passed that one out. Now let's get on to, there was something else on the agenda today. All right, we're going to open a hearing on HB 2283. And to get us up to speed on 2283, Eileen, take it away.
Thank you, Mr. Chair and members of the committee. House Bill 2283 establishes the Ensuring Transparency in Prior Authorization Act and would enact 9 new provisions of law regulating the use of prior authorization and utilization review and the provision of healthcare services. Section 1 of the bill gives the citation for the act and states that it shall be a part of and supplemental to Article 32 of Chapter 40 of the Kansas statutes annotated. Article 32 for the committee's information is pertaining to health maintenance organizations and Medicaid provider organizations. Section 1 also provides the definitions for the act. Section 2 requires that not later than January 1st of 2024, a utilization review entity utilize secure electronic transmission when accepting and responding to prior authorization requests for pharmacy benefits. This section also requires a utilization review entity to utilize and respond to prior authorization requests for healthcare services using a secure electronic portal at no cost to a healthcare provider. Section 3 of the bill requires that a utilization review entity render a prior authorization or adverse determination within 24 hours of receiving all information requested to complete a review of requested urgent healthcare services and notify the enrollee and the enrollee's healthcare provider of that determination. The section also requires an enrollee and the enrollee's healthcare provider notify the utilization review entity of the provision of emergency healthcare services or emergency admission not less than 24 hours after the admission or provision of services. This section also sets out requirements for the provision of regular healthcare services and for the treatment of a chronic or long-term care condition. Section 4 of the bill prohibits the utilization review entity from requiring prior authorization for birth by cesarean section or vaginal delivery or neonatal intensive care services, and also prohibits notification of such services as a condition of payment. Section 5 prohibits retroactive denial of prior authorization for a covered healthcare service unless the prior authorization was obtained based on fraudulent information. Section 6 of the bill states that a healthcare provider may appeal any adverse determination of a prior authorization request. Section 7 of the bill provides for a process by which a provider may be exempted from prior authorization requirements if in the most recent 6-month period, the health maintenance organization or insurer has approved or would have approved not less than 90% of the prior authorization requests submitted by the provider for such a specific healthcare service. Section 8 of the bill requires that a utilization review entity disclose all of its requirements and restrictions related to prior authorization and requires that each utilization review entity submit a statistical report about the utilization review entity's prior authorization practices. Section 9 is a severability clause, which means that if any portion of this act would be found unconstitutional or invalid, that a section would be essentially severed from the act and the rest of the act would still be valid and in effect. If enacted, House Bill 2283 would become in effect upon its publication in the Kansas Register. And I do want to say one thing, that now that I've briefed the bill, I would like to mention that if the committee is of the mind to work the bill, there are a number of issues that would need to be corrected with amendments. And I'm ready to work with the involved parties to make that happen. And with that, Mr. Chair, I can stand for questions.
Okay. I think this is the most extensive bill we've seen so far. Do we have any questions for Eileen regarding the structure of the bill itself? All right. I think your explanation went into such great detail that we were all stunned and couldn't think of any questions whatsoever. All right, now we do have a list of folks as proponents and opponents. We have them on WebEx, we have them written. So as near as I can tell, it looks to me like we have 15 people with an hour and a half. Basically, I'm not going to set a timer on the testimony, but try to be conscientious and keep it in the 4 to 5 minute mark. That way you'll be able to have any questions asked of you, and we'll still be able to get everybody in. When in doubt, try not to be repetitive so that we can keep everything within 5 minutes here. All right, so let's get rolling. Our first proponent that I have listed is none other than Chad Austin. Welcome to committee, Chad.
My name is Chad Austin. I'm with the Kansas Hospital Association. The Kansas Hospital Association represents 123 community hospitals, as well as other types of hospitals and healthcare organizations. I do appreciate the opportunity to be here today in support of House Bill 2283, which was developed with many other healthcare provider organizations. The proposed legislation seeks to put parameters on the practice of prior authorizations. In its original form, prior authorization was the process by which healthcare insurers determined whether a patient had coverage for a certain medication or service. Prior authorization requires a prescribing physician or the patient to submit a request for coverage before the patient may undergo treatment or fill a prescription. The insurer then determines whether the request is medically necessary or it can be done in another manner. From our members' perspective, the pendulum has swung too far in regards to prior authorization process. We hear every day from our members, hospital CEOs, about the frustrations that they hear from their physicians. We hear from hospital CFOs about how much it's adding to the cost of health care within their hospitals. And we hear from frontline nurses about how frustrated they are at the paperwork, delays, and challenges it causes the patients that they serve. So what will you hear today? You are going to hear from healthcare professionals that deal with this issue on a daily basis and the impact on the patients. You may also hear from opponents who believe this isn't an issue, that they don't require prior authorization or they use other methods to ensure appropriate care. They may also indicate that this may be negotiated in contracts. However, from our perspective and understanding, it's incorporated in policies and procedures, or they may suggest it's providers not understanding the process or the fault of other insurance carriers. Regardless, we know today that Kansas isn't the only state that has dealt with this issue, as there have been other states that have been focused on this and are putting together parameters related to the prior authorization process. Kansas hospitals believe that House Bill 2283 is a common sense approach that achieves balance and establishes parameters. Specifically, the bill modernizes an outdated process, streamlines the timeline for prior authorization so that when additional information is requested, it occurs in a timely manner. It expedites processes so that peer-to-peer consults for complex medical cases can be done right away rather than waiting for a preliminary denial. And it creates transparency in what the requirements are so patients as well as providers know what is being asked of them. We hope that after today's hearing, you will understand a little bit about the problems with this system and the impacts it's having on your constituents and Kansans in general. And we hope that you will support House Bill 2283, and I'd be happy to stand for questions at the appropriate time, Mr. Chairman.
Excellent. And due to the large number of people, let's go ahead and, are there any questions for Chad right now? Yes, Representative Bergquist.
Very brief, in response to your initial comment, do you look at this bill as being a solution?
We do see it as a solution of trying to minimize the administrative burdens that are being placed on healthcare providers.
All right, thank you.
Representative Haskins.
Since you're up there, thank you, Mr. Chair. Point of clarification on your third paragraph. According to a survey conducted with our Kansas hospitals, every respondent. How many respondents were in the survey? Was it all 123? I just was kind of curious.
We have 123 hospitals, and I believe we had about 2/3 of the hospitals participated in the survey.
Thank you very much.
Can this cause surprise billing instances when they go back and deny after it's been approved?
Right, and so that's one of the issues that we're dealing with, and so you'll hear from some of the other conferees that will talk more specifically about their experience with the prior authorization process.
Thank you, Mr. Chair.
Representative Blue.
Thank you, Mr. Chair. Chad, I had a chance to speak with Clara Barton in University of Kansas Health System in Great Bend, and Clara Barton really, one thing that really stuck out to me is that there are 4 RNs who are just doing prior authorization on the phone, and that's it. So I'm curious with your hospitals, I mean, how many healthcare workers do you think we're really talking about that are no longer on the floor helping patients, but they're on the phone with insurance companies?
Right, and I appreciate that question, and I would say that there's a lot more now than there was a number of years ago, and I believe the conferees today will be able to talk more specifically about the additional administrative burdens that's placed on their practices or their facilities and what they're needing to do to be able to get those procedures, that medication approved.
Could I just ask that my question be marked for the conferees if they could address it when they are speaking?
That's cheating.
Thank you.
All right, I see no other questions for you. Very good, thank you. All right, next up, I'm going to be changing it on the agenda a little bit here because we've had some time notifications come in. So next up, I'm going to call on Rochelle Colombo.
Thank you, Mr. Chairman, members of the committee. I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society. KMS represents physicians in every state, in every community across the state of every specialty. And we worked with the Kansas Hospital Association for the introduction of House Bill 2283. We brought a bill last year on this same subject. This has been a long-standing issue that I think has been very well described by my colleague, Mr. Austin. Really, the question before you today is about the balance between cost control measures and patient care. And as you've had it described to you, prior authorization is really that. It is a cost control method that is put in place by health insurers. But it is our belief that if a service is covered by an insurer, then a physician should not have to waste costly time to get that care delivered. Prior authorization delays care, which results in lower quality care. It's not good for patients, and the balance is misaligned. And so we believe this is the appropriate time to look for those solutions to decrease the administrative burden, which is delaying care and decreasing quality of care for Kansas patients. I'm going to leave it with that and allow the experts to talk about their daily experience with this, but I am happy to stand for any questions at the appropriate time. Thank you.
Right, excellent. Any questions for Rochelle? All right, seeing none. I'm going to call on the IT guru to call up. We have one practitioner who couldn't quite clear his schedule entirely, so we're going to try to get him in now, and that would be Dr. Grunbacher. Is he on the line right now?
Can you see me and hear me?
There you are. Yes, now we can.
Okay. Hey, thanks. I appreciate you letting me testify via this technology. I'm in Quinter, so yeah, last kind of second couldn't clear everything out. I got a procedure here in a few minutes, so after I'm done with this. So, but thank you for the opportunity to present testimony today. My name is Doug Grunbacher, and I'm a board certified full scope family physician in Quinter. I'm testifying in support of HB 2283 on behalf of the Kansas Academy of Family Physicians. The KFP represents nearly 2,000 family physicians, resident physicians, and medical students across our state, providing quality health care and good health outcomes for our patients, guide our policy work. So prior authorization is a huge problem for us and is a cost-saving tool that health insurance companies use. So when a health plan requires prior authorization as a healthcare service, the physician must submit paperwork prior to the proposed service. Then the health plan's payment is conditioned upon plan's approval of the prior authorization request. Prior authorization is often very burdensome and can present a significant impediment to optimal patient care. It causes delay in medically necessary care, which may detrimentally affect patient health and finances. Excessive prior authorization requirements also create administrative hassles for physicians and consume time that otherwise would be devoted to patient care. Patients and physicians would like to reduce the intrusive effect that prior authorization has on the patient-physician relationship so that the care that's truly needed to help keep Kansans healthy can be provided in a timely and efficient manner. The American Medical Association recently released a few relevant statistics. 91% of physicians report delays in care due to prior authorization requirements. 28% of physicians reported that prior authorization has led to patients having a serious adverse event. 75% of physicians report that prior authorizations can lead to patient treatment abandonment. 91% of physicians reported prior authorization creating a significant or somewhat negative impact to patient outcomes. 86% of physicians see prior authorization as a high or extremely high burden, and 88% say the burden of the process has increased significantly over the past 5 years. And so while statistics are important resources, real-world accounts of the burden to physicians and patients is more relevant. My clinic personally struggles with the burden of prior authorizations every day. We have one full-time nurse who spends at least half of every day addressing paperwork related to these issues. We have a practice of 5 physicians. It is infuriating when we spend significant dollars on labor to approve a medication that is inexpensive and the patient's been on for years, and then we get this report saying, hey, you need to go through this process on something that they've been on forever. On a personal note, my wife recently had a personal experience that I would like to share with you regarding prior authorizations. So she had heavy menstrual bleeding, which was leading to either a hysterectomy or a medication called Myfembry to slow or stop her breathing. She received the prescription in May from her doctor last May. Our pharmacy submitted to insurance. It was denied. The office appealed it, sending the same records of her ultrasound labs, office visits, and again denied. More paperwork was submitted, and eventually it was approved, pending my wife getting a $300 bone density test that really wasn't indicated, and that the insurance company wouldn't pay for. And eventually we ended up doing it just to get the medication approved, but it wasn't helpful at all. Eventually everything on the requirements were met, and 6 months later, in November, the medication was approved. Since then, her bleeding has slowed tremendously, and she's been able to avoid a very expensive medication, and she suffered extreme fatigue and anemia, which caused her to almost throw her hands up to have a hysterectomy last fall. And I can't imagine non-healthcare workers navigating and persisting through this process in order to get the care they need, but this happens all the time. HB 2283 would be a tremendous help to physicians in treating our patients when the prior authorization is required for patients to obtain necessary medical care. But HB 2283 would help us, physicians and patients alike, because it would help make the health plan's prior authorization requirements more transparent. Knowing what the requirements are in advance of providing services helps us save time for our patients and our practices. Additionally, some physicians routinely have prior authorization requests approved by the healthcare plan, yet they receive no relief from continued administrative burden of the healthcare plan's prior authorization requirements. HB 2283 seeks to address this issue with an exemption so that physicians with a demonstrated approval record may focus more time on patient care. Insurance companies need to stop creating hurdles to maintain the physician-patient relationship. Unquestionably, prior authorization is a significant hurdle. HB 2283 would not eliminate this hurdle altogether, but it would help us make it easier to navigate and make healthcare plans more accountable for the processes they put in place. We believe HB 2283 will be highly beneficial for Kansas patients and physicians alike. Thank you for your time, and I'm happy to answer any questions.
All right. We may not have Dr. Grunbacher for long. Does anyone have any questions for him? Yes, Representative Haskins.
Thank you, Mr. Chair. Thank you for your testimony. I just had a couple follow-ups. In your testimony, you said you understand the rationale for prior authorization process. So you're not advocating that prior authorization should cease. You're just saying that it is something that needs to be revisited because it's a burden to administration or to administrate.
There is a point to healthy prior authorizations in the fact that it is an effective way to decrease the cost to the medical system. And there's no doubt that obviously we all know that there's excessive cost involved in the system. But it needs to be more transparent, it needs to be helpful. And that's certainly something that we feel strongly about, but
Sure.
it's overwhelming. I could see where we have one or two things happen a day where it's something that we can deal with, but to deal with one full-time equivalent per 5 physicians to take care of this stuff, it's silly. It's just silly.
Thank you. And just one other point of clarification. I was trying to find this report that you stated from the American Medical Association, and it seems like they surveyed 1,000 practicing physicians. So it's a significant number of physicians that have been surveyed on that. So 91% is pretty significant when you deal with 1,000 physicians. Thank you.
All right, any further questions? Yes, Representative Dodson.
Thank you, Mr. Chair. Thank you, Doctor. I may have had a misconception here. When I talked to some of our local hospitals, it seemed to me like prior approvals served a purpose for the ability of the administrator to look at a particular plan, a medical plan, and quickly determine whether or not a procedure was covered. What I understood was the problem was when it was not in that plan, trying to get approval for a medical procedure which was really at the discretion and the professional opinion of the doctor, which might be in opposition to what was in the medical plan, was the problem. Have I got that right, or have I got the words wrong?
I don't know exactly what your conversation was, but what I can tell you from personal experience is that physicians want to practice medicine and not be told by the insurance company how to practice. Does that make sense?
Yes.
And so if we feel like there's a necessary treatment, a necessary procedure, a necessary evaluation that needs to be done in the best interest of the patient with a good economically sound decision, then we would like to have that done and accepted and given to the patient so that their health can get better.
If I can, there's a follow-up. One of the things that it was in this conversation was the continuing advancement of technology and processes that perhaps were leading what might be in these medical plans, and therefore, you know, it was causing a lot of backup simply because the doctors knew of this and the insurance companies hadn't caught on to it yet. Can you comment on that?
Well, I think the newest medications, the newest treatments traditionally are the most expensive treatments a lot of times. And so they are the ones that probably merit prior authorizations a little bit more. From a personal standpoint, I can tell you that there are treatments that we have and tests that we have that we've been using for years that they're making us go through prior authorizations in order to get those things done. I mean, they're getting done. For instance, and this is a little bit of a different situation, but whenever I have somebody who needs a CT scan of the head for maybe a head injury or maybe a headache or something along those lines with certain insurances, the best way to get that done expeditiously, quickly, and they'll tell me, is to send them to the emergency room create another charge for the patient so that they can get the CT scan done in that way. It's absolutely silly. Whereas if I did it from the office, went through the prior authorization plan, waited an hour, waited a day or two to get it all approved, which no doubt it would get approved, then it's just, there's silliness involved in the process and it needs to be fixed.
Thank you very much, appreciate it.
Representative Neighbor.
This is to help you, General Dotson. The issue, I think, here is that, and my mind just went blank, that's not good for me. I need a CT scan. But the...
You should ask before.
The thing is that a lot of people are in need of the care when they go to the office. And you may call an insurance company, and by the way, there's about 6,000 insurance companies with offshoots, multiple Blue Cross Blue Shields, multiple different levels of Advantage, all of those. So when they say, look in the book or look on the list, it's not always there. They have medications by tier 1, 2, 3. They have certain tests. I mean, Medicare is great. You have to get old to get that, though. And but under that, there are a lot of tests, whether it be a colonoscopy or an EEG for a nerve damage or something like that. All of that has to be done up front, and that can take, I have a daughter that's been waiting 3 weeks and had the injury 2.5 years ago. That's not correct.
Thank you very much, I appreciate that.
All right, any further questions for Dr. Grunbacher? Seeing none? All right, thank you for being here.
Okay. Thank you very much. I appreciate the opportunity.
All right, next up, I have Dr. Antonios from Ascension Via Christi. Welcome to committee.
Good afternoon, Mr. Chairman and members of the committee. My name is Sam Antonios. I'm a physician, and I currently serve as the Chief Clinical Officer for Ascension Via Christi. We're one of the largest healthcare systems in the state of Kansas, and I'm grateful for the time this afternoon. You mentioned, Mr. Chairman, that you're interested in solutions, so I will start right away about why I think House Bill 2283 is providing solutions, because it will mainly achieve the following 3 goals or outcomes. Number 1, it will help prevent unnecessary delays in providing critical care. Just like the example that you've heard, we have heard from our physicians many examples of delayed care for things that should not be delayed. And unfortunately, that is going unnoticed without oversight. Number 2, it would help reduce the administrative burden. It's a significant burden that has been compounded by the workforce shortages that we've been experiencing at hospitals and healthcare facilities. I heard today from the doctor that they had a full-time person in their clinic to manage a prior authorization, and one of the hospitals just earlier mentioned there was 4 RNs for the hospital. We have, with our utilization management department, just for the hospitals, not counting the clinics, 20 RNs who are doing this on the phone every day, trying to get prior authorizations done for patients who are in the hospital. A lot of times these are patients who have been through the emergency room, but they still require some degree of authorization. The third goal, as part of the solution, is it will just provide greater transparency to patients, providers, and the current processes that exist. It's important to understand that providers in Kansas must navigate very unique and various prior authorization processes. They're not all the same, to your point, Representative. The arrangement has increased administrative burdens, and there are studies that have been out there that have calculated about 13 hours on average per week for a physician's practice to be able to manage the paperwork. The administrative burdens are high. The associated delays can serve as a barrier to a patient from obtaining the necessary treatment, and this could be for days or weeks, and in many cases, the delays can lead to a patient just abandoning what they had set out to receive. In a survey by the American Medical Association, the 34% of the physicians nationally reported serious adverse event that has occurred to a patient due or as a result of delays in getting prior authorizations. In Kansas is no exception. Clinicians across the state are reporting concerns about delays. The delays have direct negative impact on Kansas health outcomes. Hospitals here in Kansas and across the U.S. are dealing with historic staffing shortages due to ongoing problems with finding the workforce. We recognize, or we all recognize that there is a place and time and there's an importance for utilization management, but it has to have the correct oversight. Studies are consistently showing that administrative burdens such as the various prior authorization requirements do add to burnout rates and exacerbate the existing workforce shortages like I just mentioned. So House Bill 2283 will help address the shortages and the workforce challenges. It will help with better navigation of the system, and we want our physicians to be rather focused on delivering the care that they are set out to do. House Bill 2283 sets out clear requirements in terms of timeframes for prior authorization processes, including requests for additional information, timely review, and appeals. And the legislation will recalibrate the process in Kansas to center around the patient and the provision of high-quality care in an appropriate, timely, and safe manner. It would also bring vital transparency to a process that otherwise can be opaque. By establishing clear parameters in the prior auth process, HB 2283 will strengthen the confidence in our healthcare system and provide patients and providers with the transparency they need to navigate the processes effectively. So, unfortunately, I have to head out after my testimony, so I will entertain any questions now.
All right, and we did kind of bump you down the list. I know you were supposed to be earlier. Dr. Antonio, any questions for Dr. Antonios? Yes, Representative Collins.
Thank you, Mr. Chair. You said you have 20 people on staff to handle pre-authorizations. Is that for the whole Via Christi system, or?
Just the hospitals, yes.
So all the Via Christi hospitals?
Correct. That doesn't take into account the staff who are working in clinical outpatient practices who are also making phone calls. I don't have that number with me.
Okay, so it's definitely total more than 20 then?
Yes.
All right, thank you.
Right. Committee, further questions? Seeing none. All right, thank you for being here, Doctor. All right, next up, we have Dr. Steve Stites from the University of Kansas Health System. Welcome to committee.
Thank you, sir. Thank you, Mr. Chairman. And thanks to the members of this committee, Vice Chair Penn, Ranking Minority Leader members, et cetera. I was driving here today. I'm still a practicing pulmonary physician. I take care of patients with end-stage lung disease, chronic health conditions. I got a call from my office. The prescription I had given to a patient earlier this morning had been denied by the insurance provider because they said it wasn't the right medication, despite the clear clinical indication. So while driving in my car coming to Topeka, I had to help fight our way through getting this patient this needed medication. Unfortunately, the nurse who I've worked with for over 20 years spends about 25 to 50% of her time taking care of prior authorizations for care to get the patients to get the care they need. Not completely unusual. It's different in a primary care setting, but if you look at an end-stage chronic disease setting, you'll spend enormous amounts of time trying to negotiate this part of the healthcare system. Prior authorizations are not in and of themselves bad. We used to have a system that worked. They started back in the 1960s. They started with utilization review when people were admitted to the hospital with barium enemas, and it became clear that hospitals and physicians were perhaps profiting from some of that. But healthcare has changed. And unfortunately, something that was originally meant to help control costs has become a way to help avoid costs by insurance companies. And that shift in what the objective has been has led to delays and problems for patients. Techniques have escalated over time to become so hard to navigate it. It becomes a morass of fax numbers, emails, phone numbers, and the attempts to try and delay care. That's the challenge. We don't stand against the idea that we need to have prior authorization. We stand against the confusion and the morass, which House Bill 2283 helps to address. Here's a story. Last December, we had a patient who needed a ventricular assist device at the University of Kansas Hospital. That's something you use in end-stage heart disease when you have heart failure and your life's in danger. On a Friday afternoon, we tried to get that. Well, the insurance company couldn't get to it that day. They couldn't get it over the weekend because they didn't have anybody that could authorize it. There's nobody to escalate it to. And so finally on Monday, after the patient's life hung in the balance, we were able to get approval and take a now sicker patient to the operating room to get that ventricular assist device. That challenge exists for us all the time. And those challenges are not the right way to treat people. And we can do better. And House Bill 2283 does address exactly that issue and makes it better. You've heard the statistics from the American Medical Association in a survey of over 1,100 physicians. Do physicians ever agree on anything? Not so much. But when 91% of them say that this is a problem, when 84% says it's leading to delay and harm to patients, that's an unusual circumstance for over 1,100 physicians to have that type of an agreement on any subject. And it's true, those stats are true because the struggle is true. And again, prior authorization has been around for 50 years. But in the last 10 to 20 years, we've seen an important shift. It's not let's trying to work together to figure out the best path for care. It's let's try and delay, deny, confuse, so we don't have to pay. And that's what it feels like to patients. That's what it feels like to providers. That's what it feels like to hospitals. And that's why 2283 is so important. We're not trying to say eliminate prior authorization. We're trying to say it, make it rational again. Answer the phone when we call you. Try and get the authorization returned in a reasonable point of time. If you have somebody with a chronic disease, don't take a medication they've been on for years and suddenly deny it, or every time a patient has to change insurance, patients have to change their insurance all the time, the new insurance company says, yeah, we're not going to do that. We don't care what you've been on for all these years. That's the absurdity of it. And then we have to fight our way through that instead of actually trying to take care of patients. We did a study at KU. We found that just trying to transfer patients to a lower level of care took so long that we spent over 3 years in days of patients being in a hospital when they should have been at a lower level of care. Who paid for that? Everyone pays for it because it's a higher cost to the entire healthcare system when you have that kind of delay. Delay, deny, and stall. And then lastly, I used to be able to provide a peer-to-peer. I could call and get a peer-to-peer and talk to somebody who had some knowledge around it. You can't even do peer-to-peer now. It's become so difficult. House Bill 2283 addresses that issue. It addresses the nature of emergent care. It addresses the ability to not have to always reauthorize chronic conditions. It establishes that people who have a good track record don't have to go through this all the time. 2283 doesn't end prior authorization. It returns it back to where it was supposed to be, and it makes it better for all of us to get care. That's why we firmly support it at the University of Kansas Health System. Mr. Chairman.
Thank you. Representative Proctor.
Thank you, Mr. Chair, and thank you for your testimony. So the discussion that we've been having here is about how we reduce the cost of health care. The trade-off is increasing the cost of insurance, right? I mean, somebody's the bill payer. And so I'd just like you to speak to, I mean, why, you know, the way you said it, it sounds like this is a nefarious plot by the insurance companies to avoid covering their patients. Is that your perspective?
It feels that way because I'm old enough. I got a lot of gray hair. I've been practicing medicine for 37 years. I've been involved in prior auths for a long time. There was a time when they felt rational, when I could call and get an answer. And if the answer wasn't what we wanted to hear, I could talk to a peer. That's gone. It's hard to navigate the system. It's hard for patients to navigate the system. And if you think about the delays in care, does it cost the healthcare system more money to have someone sit in the hospital awaiting a prior authorization to get transferred to a lower level of care than it does to go ahead and get a patient transferred to the lower level of care? I would argue that prior authorization, the way it's done today, delays care, makes it harder for it. Did it make sense to let somebody sit in the hospital for 3 days before they could get a ventricular assist device when it's clearly indicated, I just made them stay in the hospital longer and get sicker. That's the challenge. Again, the original intent of prior authorization was to take abuses out of the healthcare system. There were abuses. I believe that the abuse has shifted and that now it's become harder for patients to access care and to get the care they need, and that delay costs all of us.
Certainly.
I mean, if you make insurance too expensive, you are going to have uninsured people, more uninsured people, because more people are going to drop out of the, are not going to be able to afford the health insurance. And so is there a way to thread the needle here where we can help them, help them with the cost-saving measures that they need to engage in order to be competitive and still address your concern?
But Representative, I don't think the current system of prior authorization is making healthcare more cheaper, and I think that argument would be a false argument. I think instead, again, we're not saying get rid of prior authorization. There are some state houses that are trying to do that. The U.S. House of Representatives has done that. I'm not saying that's the right answer. I'm saying let's sit down and figure this out. I think 2283 does exactly that. It helps reset the bar to make it logical and rational. That doesn't mean costs are going to go up because you have to answer a question. Remember, a few years ago, I could do a peer-to-peer. I can't do peer-to-peer. Did that save money by the health insurance company? I don't know why.
What got me off my log here and asked the question is, what you said was that they are delaying so that they don't have to provide health care.
Because that's what it feels like to us.
Okay, and I think that's, I don't think that's fair characterization. I agree, we can have a conversation about whether it's efficient enough or if there's a way to make efficiencies, but I don't think it's helpful to vilify one industry to make a case.
Fair enough. We stand ready to have that conversation. I invite you to come to my office and look at how inordinately crazy it is to try and do prior authorization. This is not a rational system.
And I would probably chime in that, saying that delaying people to receive a lower level of care, that doesn't sound to me like a desire to not pay. That sounds like an inefficient system that needs to be improved. So I would agree with the representative that characterizing that as delaying with the hopes of not paying I don't see that as as being consistent with the facts at hand.
Yeah, well, okay, again, I would argue, I'm fine. But come work with us and see how the system actually works in our world on a day-to-day basis. Because it becomes inordinately frustrating to try and navigate it.
And I hear that frustration. I do hear that.
So, we have a patient on chemotherapy. Patient's been getting chemotherapy, and now we want to do a dose change. We go to the insurance company, it's denied. The dose change is denied. Really? Why are you denying a dose change? Then we have to go back and navigate our way back through that. Why is that? That delays care. And in my world of critical care medicine, when you delay care, you're going to increase the cost of care. It's like, how long do you let a heart attack sit before you can do the next step? Is that better or worse for the patient? Does that increase or lower costs? In my world, it clearly increases costs.
Right. Representative Woodard.
Thank you, Mr. Chair. Those comments are a good segue for, I guess, two parts or two comments I would want you to weigh in on. One, I spent 4 years doing patient access work in an emergency department and family practice clinic, as well as in surgery and radiology. So I know the nightmare of having to go back to our providers and say, sorry, doctor, this patient has X insurance, we have a prior auth. The number of times we had to tell our ER physicians, no, you can't admit them because we have to wait till the morning for their insurance office to be open to see if we can admit them for this procedure. But since you mentioned in addition to that, you mentioned in your written testimony about retroactive denials for prior authorizations. Peeking ahead to some of the testimony, there's some comments from some of the opponents that that's uncommon or doesn't happen, but I've been there several times when it did, and just wanted to touch on what that looks like for you all.
You start people on care, and all of a sudden they say, oh, no, that's denied. Now we've already incurred the cost of that care. The patient's already incurred the cost of that care. And you're already proceeding down a road of treatment that may be hard to change. So I think those retroactive denials are difficult. And sometimes you have to get started on something, but you can't get a hold of anybody. That's a challenge.
Thank you. Thank you, Mr. Chair.
All right, Representative Blue.
Thank you, Mr. Chair. I mentioned earlier I had a chance to speak with my hospitals in my district, and the question I have is, when an insurance company denies a prior authorization request for placement, where does that patient go?
Yeah, they sit in the hospital, right? And that's where the cost of care goes up. And an insurance company may not then have to try to pay for that skilled level or whatever level of care that is. And the per diem cost may have already been exhausted in the hospital, so it may not accumulate to the insurance company any longer, but the cost does accrue to the hospital. And the patient sits in that hospital, and we continue to fight our way through it. And so that's the challenge, right? So we can say, well, the insurance company's not paying. Well, right, actually, we're all paying. And that's the inefficiency of the system. That's why I say I think there isn't. I don't think the statement was true earlier, because I think that's exactly what happens.
So to follow up, just to make sure I understood correctly, who ends up paying? The hospital ends up paying for it?
The hospital pays it. We have to absorb the cost. We're not going to put the patient out on the street. So we sit there, and so the costs are accrued to the hospital, and it just drives up the cost for everybody.
Thank you.
All right, committee for the questions. Yes, Representative Haskins.
Thank you, Mr. Chair. You sparked my interest going down the history lesson of prior authorization. Can you give me what is in the utopic world of medicine, what is the relationship between hospitals and prior authorization? What should it look like?
I would turn the clock back about 15 years when we didn't have this degree of struggle that we have today. And then that time period may not be exactly right, but I think our goal is to be able to have an honest, open conversation where we try and chart that course together. And it probably starts in committees and places like this where we address the struggle at a high level, and that translates down to a local level. So that if I pick up the phone and say to somebody, I can talk directly to a peer-to-peer provider at another at the insurance company, at Blue Cross, at United, at Aetna, whoever it is, and have a reasonable, rational conversation. I used to be able to do that. It's very difficult to access that now, almost impossible. And so if we can have that kind of world, I think we can have good conversations. But what we should try to do is preempt as much of that conversation as possible before where we've agreed on pathways to care. And we don't always do that either very well.
And if I may, just so I understand, that the prior authorization seems like if you leave the hospitals and the doctors unchecked, there'll be abuse. So it serves a purpose because you stated 50 years ago there was a need. And
the world was different then. Everything was fee for service. Everything I did, I got paid for. And today, that's not true. We get a per diem payment. Physicians still sometimes get paid per unit of charge. But if you're hospitalized, that may or may not be true. You may be capped. You know, it's very difficult because every patient, every insurance provider is a little bit different. But the world has changed. I'm not saying that prior authorization should be eliminated. Sure. Right? I'm not saying that. I'm saying 2283 is necessary reform to a system that's gone too far one way.
And my last one is, because we're going to hear the opponents, and I would like to have a comparison, what's the justification that they give for the delay, for the purpose, for why we're here right now? What justification, if you had to be honest about it, you know, what's the justification?
Man, I'll tell you, here's what I feel like has happened, Representative. Before we would call and we would talk to a nurse or a physician, and today we talk to someone who's reading from a script that hasn't been involved in healthcare. To me, that feels like it's, and I don't know, I'm not on the insurance company side of the fence. It feels a little like, okay, we've gone to lower cost solutions, and what we need to do is get back to, it may cost us a little more to get to the answer, it may cost you a little bit more, but in the end, we'll save the whole system money and will make a lot more sense to our patients. We don't make sense right now.
All right. Committee, no further questions? Very good. Thank you for being here. All right, committee, we are going to have to step up our game just a little bit here, so in order to get through all of our, and be fair to all of our presenters. Next up, we have Angie Johnson, Director of Nursing from Memorial Health System. Welcome to committee.
Thank you, Chairman Sutton and members of the committee. Thank you for the opportunity to testify in support of House Bill 2283. My name's Angie Johnson. I'm Chief Nursing Officer at Memorial Hospital in Abilene. We're a critical access facility. We're associated with Salina Regional. And I do want to take a second to answer your question about Clara Barton nurses, because I've been a nurse for 20 years and handle the scheduling or the oversight of all the scheduling. 4 nurses on an inpatient unit, one nurse can take care of 4 to 6 patients. So just think if you had 4 nurses taking care of patients, that's 20 hospital beds that could be open. Right now, we pull those nurses to do insurance verification, and so we have to close beds, and so when we get patients into their local hospital, we have to say, we don't have enough beds open, you're gonna have to try somewhere else. If it's a clinic nurse doing that, one clinic nurse can help a physician or provider see 20 to 30 patients a day. Just to give you an idea of what that means when we take those nurses out. And also, I just want to say, as a hospital administrator, I realize the insurance companies, this is a business, a hospital is a business. None of us, we all want to be able to make payroll at the end of the day. It feels nefarious on the end of the patient when you have to tell someone that you can't provide care. But we do that too at a hospital. We say, I'm sorry, we cannot do this procedure because it won't be paid, or we cannot admit you here today because you don't have a covered benefit. Like, that would cost us $20,000, and we'd probably send you a bill and good luck applying for patient financial assistance. So I don't think the insurance companies are in a room thinking of ways of who can they hurt today, but it just feels that way when you have to tell patients no. But hospitals tell patients no too. So we get it, that they are just trying to make everybody's payroll at the end of the day. The prior authorization bill you're considering today is a necessary step to help providers and nurses like me deliver care in a responsible and timely way. Thanks, I forgot it was a little shorter than most up here. When the providers look to obtain a prior auth for the suggested course of care, they're usually asked to try a different course of care or resubmit additional documentation, or left waiting for days, weeks, even months for an answer. This, of course, impacts patients by delaying care and often interfering with the best course of care. Oftentimes, the patient doesn't understand why their doctor's recommendation is denied. They assume it's the hospital's decision, when in fact it's the payer. The delays in prior auth decisions have increased in recent years, and these delays end up costing us more money by increasing care costs as condition worsens. While we do have dedicated staff to help work on prior authorization, sometimes these conversations do require nurses or even providers with clinical experience to get on a phone call, which you have to plan ahead of time and block out their schedule. This takes nurses off the floor and away from patients during an unprecedented nursing shortage. I personally have been affected by the prior authorization process. In April of 2021, I went to the doctor complaining of back and neck pain, and I do what everybody does first. Ibuprofen, warm pack, I got a massage. It didn't help because the pain continued to get worse, shooting pain down my arm, numb fingers. I was like, okay, maybe I'll go to the doctor. He recommends an MRI. I question it because I don't want the bill for an MRI. Those are $3,000 or more. And he said, you have to do that to see the nerve damage involved and to look at your spinal cord. So I was like, I listened to him because he's a doctor, and I went and got the MRI. I don't think I was out of the machine 20 minutes before my phone was ringing, and they were telling me that my spine showed severe disc problems, including a pinched spinal cord that actually had no spinal fluid even left in the area. I don't read MRIs all day, but I could sure tell it's supposed to look like a straight line, your spine, and mine had a pretty good V indent in it. I went and consulted with 2 neurosurgeons because I'm a nurse and I just don't believe one. I want to hear it twice because I was sure Tylenol could fix it. And they said I needed surgery to avoid further damage and eventual paralysis if my spinal cord completely was occluded at that spot. My insurance company denied the surgery in May. And that was the month I had my MRI. They suggested physical therapy, steroids, and pain medicine. I don't love pain medicine. I'm a single mom. I can't drive, and the stuff puts me to sleep, so it wasn't an option. I had to take time to call the physical therapy department, get in for an appointment. It also took time to call the anesthesia associates and get in for someone possibly injecting a steroid into my back, so that took a couple of weeks. I got to physical therapy. They touched the right side of my neck. My left arm went numb. They looked at my MRI and said they're not going to touch me, but they would put warm packs on my back every day for a couple of weeks if the insurance says you should do physical therapy. I went to get the steroid injection into my spinal column, and no anesthetist in the building would touch it. They would not inject. There was no room. They said they would absolutely not touch my back at all. So I thought, okay, It took a month or a half to get through those appointments. All the documentation my primary care doctor submitted to my neurosurgeon's office, because they're the ones that had to submit it to the insurance company. I was like, they absolutely have to approve this surgery. So they finally approved it in July. Neurosurgeons are blocked out on schedule for a while. I finally had my surgery in August. And it was supposed to be a 2-hour outpatient procedure. That's it. I woke up 6 hours later and spent a week in the hospital. And I was going to be in a neck brace for 24 hours a day for months. My surgeon told me when he got in to look at my back, it looked completely different than my MRI. There was no bone spurs on the spinal column, and in surgery, he had to shave off close to 15 of them that popped up from inflammation. He said it was night and day different. So here I am in a neck brace, 24 hours a day, 7 days a week. I had to wear that for months. He also had to fix the nerves going down my arms because those ended up damaged. You can't move your hands side to side or stir, so no cooking, fine with me. No driving, no moving, nothing. So I woke up, like when I said after the surgery, I was barely able to swallow because they cut from the neck and reach back to your spinal cord. They put metal from here to here instead of just in one spot. That metal plate pushed up on my throat, and I could no longer swallow and ended up in speech therapy as well. Like I said, I couldn't move my arms, couldn't drive, couldn't cook supper. I was out of work until December. So I struggled because I was worried about, can I do my job? Can I be a mother? I had no clue what my future was. And I wish I'd been given the chance to have surgery when the neurosurgeon said I needed it. I hope this bill saves someone from months of pain medication, debilitation, depression, and uncertainty. I understand the need for prior authorization to help contain costs and eliminate unnecessary testing. All we're asking for is an easy way to track it with an online portal. Right now we have nurses, some insurance companies like paper faxes, some of them like an online portal, and some of them like an email, confidential email system. Trying to figure out which one you're dealing with that day is a lot to figure out. You want to be able to provide peer-to-peer reviews so the best care can be provided, and establish turnaround times for answers so our patients don't have to wait unnecessarily long times. And I believe this bill does that. I think this bill is a great first step to accomplishing those things. Thank you for your time.
All right, committee questions for Angie Johnson? Seeing none, you have escaped.
All right, I'm lucky you guys are kind to nurses. Thank you.
All right. Next up, we have Dr. Dan Nielsen from the Kansas Dental Association.
All right, thank you for the opportunity to be here. I'll try to be brief and to the point. Chairman Sutton and the House Committee on Insurance, thank you so much for having me. I'm Dan Nielsen. I'm a private practice oral and maxillofacial surgeon, and I am the president-elect of the Kansas Dental Association right now. I thank you for the opportunity to testify in strong support of House Bill 2283 from the perspective of dentists in the dental field. Right now, House Bill, as you've already heard, provides transparency. I mean, it boils down to not only a promise to provide the treatment, but a promise to pay. And a lot of the things that you've heard from the medical side is truly life or death. Luckily, in dentistry, we don't deal with as much of that. Every now in oral surgery, it hits that point. So for us, that promise to pay, also combined with the retroactive denial, those are the two big issues that I'm hearing from the dentists that are willing to give me their time. This lack of transparency that comes, as everybody that spoke before me has hit on something that I'm going to say. If a patient has insurance coverage, both medical or dental from our end, the process can be complicated and intimidating. Dental offices across the state, we strive to try to get them through this maze. That's their dental benefits. When we go through this, we hit problems. Number one, delay, which was already talked about. Sometimes a cavity is not a big deal, but I'm sure some people have had some root canals, and that stinks. If you're fortunate enough to have the money, great, but if it kind of makes the difference of you paying other bills, it's pretty significant. Also, The issue being not being covered as provided with that document. You get this document, you spend this time, it's not as it would say. Currently, without a prior authorization, it's a guess, it's an estimate. We get on the phone, Lord knows how long that takes, and we're gonna give you something that is grossly inaccurate, and it doesn't help anybody. So we offer prior authorization in most Kansas dental offices. In an attempt to circumvent the inaccurate process that is just guessing, we offer the patient the service of prior authorization. This written communication from an insurance provider requires a dental office to file documents, x-rays, and appropriate coded treatment plans for the insurance company to review. Occasionally, the insurance company will require further information, but at the end of the process, a document is provided as the prior authorization. This document in the dental world usually takes about 3 to 5 weeks. Obviously, we're not life and death, but still, it's a long time. And if you need a root canal or something like a dental extraction, that's really not even a possibility. Folks are demanding to know what the financials are, and I don't think that that's unreasonable. The document that we get spells out the care, and we go to the patient and we say, this is what they say. What we see very frequently is not being covered as they said or not to that amount, or like I had said, the retroactive denial that comes in to be quite the problem. When we hit the retroactive denial issue, despite the delay in treatment, which has already been discussed, the numerous communications between the dental office, the insurance company, the dental office, and the patient, and the fact that the treatment has already been rendered, payments have been made, we get stuck coming back to the patient saying, gosh, I'm sorry, but everything that we told you was inaccurate. For example, 4 wisdom teeth, a very common procedure that's done on young, healthy folks. It can make a swing of $1,500. And for a lot of people, as you can imagine, they're pretty mad. And so with this process, patients being upset, what ends up happening is it kind of feels where the patient looks at us and asks, are we just incompetent with what we're doing? Are we being deceptive? I know it was kind of touched earlier with the doctor from KU Med. That's a perception, not an accusation from mine. But I actually understand where they're coming from, and we just don't really have an answer at all. With that part aside, we also run into the staff members. They've spent hours and hours. I can tell you that 30% of my staff, and I have basically an outpatient surgery center, 30% of my staff just does this. And it's my highest turnover. We call them insurance coordinators. And the job satisfaction is horrible. I know 2 dentists that are currently hiring firms that are out of the United States just to get people dedicated to their practice to make those phone calls. And to me, that's just a travesty. The scenario is this. The legal practice of insurance providers regarding prior authorization and retroactive denial is causing trust to be lost between, in my instance, dental providers / office and our patients. House Bill 2283 is a solution from my aspect. It provides financial transparency to the people of Kansas with health care. It also aligns us with 11 other states. The way I see it is there's a process, as we've talked. And if these insurance companies, we're not really asking them to do much different, but then honor what they've said. As legislature, I would ask you, legislators, I'd ask you to support this bill. And I'd also like to thank all the healthcare provider groups from Kansas that were working on this really critical matter. I've described to you the problem, but I think this bill, it was stated previously, it is a fantastic first step in making transparency and trust back with patients.
All right, thank you. Committee questions for Dr. Nielsen. Representative Neighbor.
Thank you, Dr. Nielsen. I actually worked in dental as well as medical. And I can tell you that when you have a person in the chair who needs a root canal and they're dying of pain, and you call the insurance company and they say you're out of network, they still have a value that they can tell you. But a couple of them say, tell the patient to go home and check their book. And they're in the chair and they are in pain. That's what this bill corrects. Thank you.
No further questions? All right, thank you for being here. All right, next up we have Dr. Wayne Gilmore from the Kansas Optometric Optometric Association.
Chairman Sutton and the committee, I appreciate the opportunity. My name is Wayne Gilmore. I'm an optometrist from Parsons, Kansas, and president-elect of the Kansas Optometric Association. I appreciate the opportunity to submit testimony in support of House Bill 2283. Doctors of optometry are independent primary health care providers who not only prescribe glasses, contact lenses, low vision devices, and vision therapy, but also diagnose, treat, and manage eye diseases and disorders of the visual system, the eye, and associated structures, as well as diagnose related systemic conditions. My job today, I think, is to explain briefly how this bill spills over into the optometry profession. As primary health care providers in all corners of the state, we are an integral part of a healthcare team, and often we're an entry point to the healthcare system. Optometrists and their patients often have to deal with two different types of insurance, as many patients have a vision plan that may be bundled with or completely separate from their medical plan. Depending on the reason for their visit, we bill either the vision plan or the medical plan, and in some cases have to be denied by one in order to bill the other. Obtaining prior authorizations through the current process can be confusing and doesn't always provide accurate information, and so in some cases, services are denied and deemed patient responsibility after the fact. Of course, this is confusing for both patients and providers. The bill addresses a growing problem with prior authorization, the prior authorization process for prescribing medications. For myself, barely a day goes by that I don't receive at least one or several prior authorizations for medications I have prescribed. The most common medications I prescribed are to treat glaucoma, eye infections, and dry eye. While PAs for chronic medications are a hassle and oftentimes a shell game in terms of selecting the correct name brand medication which is paired with the correct coupon or hoping a generic will be covered, it is the acute problems which require same-day treatment that are really affecting patient care in my practice. And they also have touched on, how a chronic medication, patients been on for years and it's no longer covered, so you have to go through that process. But the acute patients are the things that I see day to day that have been troublesome. When I remove a piece of metal from a patient's eye or a patient presents with a serious eye infection, it is critical the treatment with the appropriate medication should be initiated the same day. Unfortunately, if I write a prescription for something that's not covered or not on formulary, it kicks in a PA, and so there might delay treatment by a day, 2 or 3. And pharmacy PBMs, pharmacy benefit managers, their job, of course, is to control cost in healthcare, but the patient can't be forgotten. When a PBM has a name brand medication on their formulary, but the generic isn't, then that creates a whole different, more cost for the patient. And that's something we're seeing. It increases cost for the patient and delays on the patient receiving the medication on time. We stand in support of House Bill 2283 and encourage the committee to pass out favorably this much needed first step in the modernizing of prior authorization process. Thank you.
Excellent, thank you. Committee questions for Dr. Gilmore? Seeing none. Got off easy.
Thank you.
All right, thank you for being here. All right, next up we have Jennifer Laux, pharmacist from the Kansas Council of Health System Pharmacy. I should probably put my glasses on before I try to read.
Well, at least you said it, not me. Thank you. Appreciate the opportunity to talk today. So I'm here representing the Kansas Council of Health System Pharmacists in support of this bill. And I wanted to talk about two things today. So in my current role, I'm a pharmacist by training. I oversee a group of 18 pharmacy technicians that support prior authorizations, mainly for specialty medications. This was actually put into place for a lot of different reasons, but also to help with provider burnout and healthcare practitioners leaving the organization because nurses don't go to school and want to be nurses to do prior authorizations. So we tried to come up with some unique staffing solutions to be able to support our patients and getting them on medications with different team members. So we've done this with pharmacy technicians. Unfortunately, we have 5 open positions of our 18 because that burnout is occurring with this team also. The other thing I want to mention is that I think there's been a lot of comments today about the utility of prior authorizations and why are they there. And I think the specialty medication arena is maybe a little bit representative of some of the lack of utility. So when you have new medications coming out, like for example, Trikafta, a groundbreaking therapy for CF patients, there is no alternative. There is nothing out there that even compares to the outcomes of this. Yet trying to get a patient on that medication, you have to go through all of these different hurdles because of the expense of the medication. And at the end of the day, you get 95, 97% of these patients approved. So you basically have these team members spending countless hours trying to get patients approved for a medication that there isn't another solution for. So I think hopefully that adds a little clarity to some of the history. It feels like maybe prior authorizations historically were for those Me Too medications where there is another option and there is a brand name that maybe is just as good as the generic. But when we see this in our specialty patients and there really isn't another option, it's maybe contributing to some of that waste and expense. I know we're short for time, so for the first time in my life, I'm going to keep it brief and take any questions.
Excellent, and I do appreciate that. Committee questions for Jennifer Laux? Seeing none. Very good. Thank you for being here. All right, committee, just for those of you checking your watches, we will not be finished at 5 o'clock today. So one of the glories and gripes of having a 3:30 committee is that there's really no hard stop at the end of it, but we still try to get done in a timely manner. So we're going to give it a whirl, but I'm not going to cut short the opponent testimony because we're running out of time. That's not going to happen. Next up, we have via WebEx. So IT guru, take it away. We have Dr. Dina Hubbard from the Kansas chapter of American Academy of Pediatrics.
Hello. Thank you for the opportunity to join you today. Can you hear me okay?
I can. Welcome to committee.
All right. Thank you, Chairman Sutton and members of the committee. Yes, I'm Dr. Dina Hubbard. I'm a neonatologist, a pediatrician specializing in care of sick and premature babies. I'm here today as the public policy chair for the Kansas chapter of the American Academy of Pediatrics. I am practicing, and we represent over 450 pediatricians in the state of Kansas. I agree with much of what has been said already today, so I wanted to make a few specific points. Number one is prevention. We know an ounce of prevention is worth a pound of cure. That's why I love pediatrics. It's a great return on investment. So prevention, getting patients the treatment they need, the medications they need, the procedures they need in a timely manner is going to save money. It's better for the patient. It's better for the healthcare system. And so minimizing the prior auth hurdles that we have to jump is very beneficial. Number two is accountability. Right now, there is no accountability for denial of pre-authorizations or care that has been provided. So I think this bill goes a long way to start that process of providing that transparency for this process. It shouldn't be that difficult to know the criteria. Physicians and other healthcare providers have gone to school for a long, long time. For me, it took 14 years after high school before I could practice. And I still have a hard time finding out the information that I need for my personal insurance. So it needs to be readily available, electronic, as has mentioned. We don't need to do the paper forms. We should standardize forms actually so that it's not a different system, different paperwork for each insurance plan. But accountability is a big one, I think. I think there should be an incentive for insurance companies to approve prior auths in a timely manner. And when they don't, and it should have been approved because based on the evidence and the care, they need to have consequences. As healthcare expenditure has gone up, believe me, it's not going to the physicians and nurses, not even hospitals. We're seeing record profits by insurance companies. So there needs to be some accountability there. The next thing I would say is equity. In pediatrics, everyone thinks that, or many people may think that kids are just little adults. But the truth is that there are many kids with special healthcare needs, complex needs, and they are at an increased risk of not getting the treatments and medications and procedures they need because they have complex medical needs. And so they're going through this prior auth situation over and over and over. And so it's making it even more challenging for those already at-risk kids. I'm a big fan of lean methodology and decreasing waste. One of the ways that we can save money is decreasing waste and inefficiency in this process. And I think House Bill 2283 goes a long way to this. So I mentioned prevention, accountability, transparency, equity, decreasing waste. The last thing I want to mention is that it often feels like insurance companies are practicing medicine without a license. It's a barrier to the doctor-patient relationship, and they do have a conflict of interest. And so I would request that the committee strongly consider and support House Bill 2283 so that those that have trained for years and years that really want to do the best thing for patients are not handcuffed from doing so. Thank you very much.
All right, thank you. Committee, do we have questions for Dr. Hubbard? Yes, Representative Haskins.
Thank you, Mr. Chair. Thank you for your testimony. And before we move on to the opponents, I was just going to give another opportunity for you or for any of the proponents to explain the justification of and the rationale of why we are currently in the prior authorization situation. What justifications do the insurance companies give you?
I think it's probably most appropriate that we ask the insurance companies, the opponents to the bill, this question.
Well, I plan to. I was just asking for a
Let's get on to that part of the testimony because we've used quite a fair amount of time on the proponents.
We'll save it as a teaser then.
There you go.
Got it.
I think that's a great.
You're off the hook.
Excellent, and thank you for being here. All right, committee, you'll notice that we also have a significant amount of written testimony. So be sure to read that in your off time. Now, let's turn are there any other members who would like to speak as a proponent? We've gone through the entire recorded list. Is there anyone else who would like to speak as a proponent? All right, seeing none, I'm going to close proponent testimony. We'll go to, now I have no one listed as neutral. Is anyone strongly neutral on this issue? I can just, okay, let's go ahead and close that neutral testimony out too. We're going to go to the opponents now. First off, I have a WebEx listed as our first opponent, and that's Matthew Ness with the Director of Government Affairs, Healthcare on behalf of Cigna, Evicor Healthcare on behalf of Cigna. I missed that word. Matthew,
Yes,
are you here?
I'm here. Can you all hear me?
Yes, I can hear you there. Very good.
All right. Well, thank you very much, Mr. Chair and members of the committee for giving us a few minutes to talk. I'm just going to make quick introductions. I have partnering with me today one of our clinician leaders at Evicor. And so between the two of us, I'll be doing most of the talking, but I wanted to make sure she had an opportunity to chime in specifically from a clinician's perspective. So Dr. Charnia, do you want to just introduce yourself briefly and then turn it back over to me? I think you might be on mute.
Okay, well, can you hear me now?
There you are. Now I hear you.
Perfect. Thank you so much. Hi, everyone. My name is Rosaline Chirania. I'm a board-certified medical oncologist, hematologist, and internal medicine doctor. After being in a multi-specialty oncology clinical practice for over a decade, I joined Evicor about 8 years ago. I serve as the executive medical director for oncology imaging. And in my position, I have oversight over the Evicor's diagnostic radiology as well as the medical oncology programs, the day-to-day operations, as well as development of evidence-based policies and guidelines that align with several of the nationally recognized cancer societies. Thank you for allowing me to introduce myself. It's an honor to be here, and over to you, Matt.
All right, great. Thank you very much. So my hope is between our two areas of expertise, we'll be able to answer any and all questions you throw at us. So we are certainly not neutral. We are standing opposed to this bill. And I'm going to, before I get into some of the details, and I'll try and be brief, because I know we're over 2 hours into this committee hearing in the afternoon. So let me just take a step back and do some level setting here. So you mentioned Cigna, Mr. Chair. That is correct. Evicor is a part of the Cigna family, but we are also an independent medical benefits manager that does prior authorization utilization management, not just for Cigna, but for about 100 different payers all across the country. So pretty much all the major payers that you can think of, Evacor in some form or fashion does utilization management for. So we are the nation's largest medical management company. We have over 25 years experience across 11 solutions. We call them solutions for utilization management. And that runs the gamut from cardiology to radiology, lab management, post-acute care, to just name a few. And so really what we do is we try to help partner with the providers to ensure that the care that's being requested is in line with the latest evidence-based medicine. And I said that very slowly for a reason, and I'm going to talk about that in my testimony. So let me talk about, so why does prior authorization even exist, right? So I'll give you two answers for that. One is the ongoing rise in healthcare costs, right? I think we've all seen there's just been a significant increase in the amount of healthcare costs. And if you look at that as a part of our GDP, it's enormous. The other part, and the part I'm going to really focus on in my presentation, is the ever-increasing pace of innovation, right, and the generation of medical knowledge. Those are the two real aspects of why prior authorization exists. So first of all, prior authorization, right? We look at it first and foremost as a patient safety tool that ensures the right care at the right time, okay? So medical knowledge is doubling at a rate of 73 days, okay? So there was a study from a professor at the University of Iowa that shows in 2020, if you look at the pace of change in the current healthcare system, 73 days, there is a doubling of medical knowledge, okay? So just think about the coronavirus, right? So look at COVID-19. We went from nobody a couple of years ago even heard of the COVID-19 to a couple of years later having a vaccine. So if you extrapolate that out to the entire healthcare spectrum, that's sort of what we're dealing with, right? So there is just an incredible pace of change in the medical field, which is awesome for everybody. But we need to understand, okay, that in 2019, there was a study by this group called Choosing Wisely, where physicians, this was a physician group, estimated that up to 30% of all healthcare offers no clinical value to patients. And to bring that down to a little bit more of a micro level, talking about the pace of evidence change. So there was a study in 2019 by a group called the National Comprehensive Cancer Network. They're a not-for-profit leading cancer center that promotes patient care and research. Just in that 1 year alone, there were 170 guidelines updates across 54 cancer types. There were 18 new oncology drugs that were introduced for 28 expanded indications. To give you another stat, there's a group called Doximity, which is a physician-run group, that showed more than 2/3 of physicians report feeling overwhelmed by the amount of information that they have to keep up with. So when you're talking about all of this medical knowledge that's really awesome and coming out all the time and it's helping us, it's impossible for physicians to keep up with that pace of change. That's where prior authorization comes in. So, let's put a number to it, right? So wasteful healthcare spending, this was a 2019, I believe 2019 or 2020 publication in the Journal of the American Medical Association. Wasteful healthcare spending is estimated to be as high as $935 billion with a B, $billion annually. So there is an incredible amount of overutilization that takes place. Now, are doctors doing that out of malice? Absolutely not. 99.999% of doctors absolutely are trying to do the right thing. But as I just mentioned with my stats, is that it's impossible for these physicians to keep up with that. So I just wanted to sort of level set on prior authorization, just take a couple of minutes to talk about that. What I want to focus the rest of my presentation on and to address head on is gold carding. So we've heard some arguments around gold carding. We as an organization certainly don't agree, and here's why. I have traveled around the country and have heard this. We all probably are aware that Kansas is not the only state to introduce legislation. There were 13 states last year that introduced some sort of gold carding legislation. All of them failed once they had an understanding that this is all based on a flawed premise, and I'm going to talk about that. So it is based on a flawed premise. So the bill before you today has a 90% threshold, okay? So what does that mean? 90% sounds good if you're taking an algebra test, right? That's an A. 95% is excellent. But you flip that around, and what that says is we're asking patients to accept that even the best providers will get their care wrong 10% of the time and remain unchecked for a period of time. I believe it's 6 months in Kansas. So that inappropriate 10% of surgeries, unnecessary radiation, duplicative testing, that's going to cost patients, right? It's going to cost patients financially. We know about 50% of at least the commercial population are on high deductible health plans. So if they're getting an MRI that they perhaps don't need, or a CT scan that they don't need, or a spine surgery that they don't need, they're going to be paying out of pocket for the deductible or whatever that cost may be. More importantly, it's going to affect them physically and mentally through unnecessary out-of-pocket costs, right? There's going to be delayed access to evidence-based care, exposure to potentially harmful care, and all these negative impacts don't occur out of malice, but just because, again, medical knowledge is doubling, and there are all these blind spots and outdated practices that providers, are just simply not able to keep up with. So I'm going to talk a little bit more in depth about gold carding. So what is gold carding going to do? It's going to decrease patient quality, and it's going to increase costs, right? So simply because that provider reaches that approval rate does not mean that they will continue to order appropriately in the absence of a utilization review program. In fact, gold carding has been shown to be unsuccessful in encouraging long-term positive behavior change. Utilization review also creates a sentinel effect, whereby the performance improvement occurs because providers in a program know they're being evaluated. And so without utilization review, that improvement dissipates. And there was a study published in the New England Journal of Medicine found that when incentives were removed for physicians in the UK, primary care practices, there were immediate reductions in documented quality of care across 12 indicators. And conversely, there was little change in performance on the six quality measures for which the incentives were maintained. One of the things that we've heard over the 2-hour proponent testimony is the administrative burden. And as an organization, we absolutely want to work with the providers and understand that prior authorization inherently can be an administrative burden. We certainly understand that, and we're not shy about saying that. But when you have, in a gold card program, when you have a certain set of rules for some providers and not others, that's going to create so much confusion and only add to the administrative burden of delivering healthcare. Physician groups will have to now navigate operating under different standards for different providers, for different CPT codes, and that is likely to result in delays, errors, and lost efficiency. Elimination of other utilization review benefits. So gold carding would also eliminate several other utilization review benefits. And probably the most important one is alternative recommendations. So one of the most important part of prior authorization is, again, we're not saying no. Our denials are very, very low. What we're saying is you don't need, you have a patient, right? So our chief medical officer often says when he's speaking, who is a pediatric oncologist, that he comes up against cases all the time where there's actually delay in care in prior authorization. So he had one particular example he cites is a young boy who came to him, this was when he was practicing, and he ultimately had suspected cancer, cancer in his brain. And the provider ordered a CT scan, and the provider, it was denied. And so, as a matter of fact, it was denied by Evercore. And so the provider called in for a peer-to-peer, very, very angry. And Dr. Gracious, our CMO, mentioned that if you do a CT scan, you're not going to have the image that you need. We think, and if you want to change the recommendation right now from a CT to an MRI, the latest evidence-based medicine suggests that this particular patient does not need a CT scan. This patient, in fact, needs the more expensive MRI. And I know it can be difficult when you're sedating a young patient, right? And it's a little bit of a hassle. But if you do the CT scan, you're not going to get the image that you need. So you're going to have to do an MRI. And so you're going to have to schedule the CT scan. That's going to take a week or two to schedule. And then you're not going to get the information that you need. This is according to the latest evidence-based medicine. So you're going to have to go ahead and get the MRI. Whereas let's not do the CT scan. Let's go ahead and go straight into the more expensive MRI so we can determine how to best evaluate that patient. So that is one of the things that is really lost within prior authorization is the ability for our providers. We have about 400 doctors on staff that sole job is to look at look at the latest evidence-based medicine and making sure that we are partnering with the ordering physician to make sure the patient, at the end of the day, this is about the patient, is getting the right care at the right time, at the right setting. And when you take gold carding away, it loses the ability to provide for those alternate recommendations that ultimately will benefit the patient. So with that, I'm gonna, let me just say this. So there was one of the gentlemen who mentioned, speaking of administrative burden, who mentioned the bill that's in the House of Representatives. I would encourage you all to take a look at that. So what he was referencing was the Seniors Timely Access to Care Act. And when you go on to ks.gov and you look into the fiscal note, the Congressional Budget Office put a $16 billion price tag on that particular bill. That bill does have some gold carding language in it. That bill, so again, had that $16 billion price tag. We are not talking about an insignificant amount of money. There's some huge financial implications that ultimately will not benefit the patient. So with that, I'm going to stop. I don't know if Dr. Sharani, if you have anything that you want to add on. Certainly, we're happy to take some questions for you and hopefully answer them the best way we can.
All right, I do have one question from committee. Looks like there's a couple. Representative Collins is first up.
Thank you, Mr. Chair. And I was just wondering, the people who make the decisions decide on an individual basis if pre-authorization is granted or not. Are they medical professionals?
I can tell you that payers are constantly looking at what needs to be prior authorized and what doesn't. Only about 15% of medical services are actually, there's a prior authorization process for that. So I think sometimes you'll hear that everything is being prior authorized. That's not necessarily true. That answer is, that statistic is about 15%. As far as who gets to determine what is prior authorized or not, I certainly can tell you that clinicians are involved in the process. There's this look at, okay, what particular CPT code is being overutilized. This always comes down to what's the most complex, high cost services that really need to be reviewed, right? So an X-ray, for example, most payers don't do prior authorization for X-rays. They're not high cost. And they generally, there's just not really a need for that. But when you go into imaging scanning like CTs or MRIs, where in some cases you're injecting unnecessary or radiation that may or may not be unnecessary, that's when prior authorization would come into play, something along those lines.
All right, thank you. Thank you, Mr. Chair.
All right, very good. Representative Underhill.
Thank you, Mr. Chair. At the beginning of this, the chairman asked for solutions if you were going to speak, and maybe I missed something, but you just spoke for 10 minutes, and the only thing that you said was that you agree that administratively this sucks, but you don't agree with any of the solutions provided. So where's your solution?
Yes, sir. And I'm really glad that you brought that up. I didn't want to take too much time, but that's certainly really important. We do have solutions. Some of the proponent testimony we agree with, right? So continuity of care, that was one of the ones that was brought up. And it's one of the AMA 21 principles of prior authorization. So continuity of care generally means that, say on December 31st, you have Aetna, and then on January 1st, you switch health plans to Cigna, whatever, pick a payer. That prior authorization, we believe, should follow that patient for a certain period of time. We think that that is certainly a reasonable request. Another request, sir, that was brought up are on turnaround times. So right now, Medicare has a 14-day turnaround time. I think there's some opportunities there, and there's some language in the bill addressing this around reducing turnaround times. I think there's a happy medium there. I think we could certainly do better than 14 days. But I think 24 hours is too tight. And I'll tell you why. Because what happens is When you put a 24-hour turnaround time on a benefit manager to turn around, you actually have the unintended consequence of increasing the number of denials. So there is always a happy medium there. Another area that we would wholeheartedly agree with is electronic prior authorization, right? We, as a benefit manager, we process 100,000 prior authorization requests every single day. So we are very good at this. We do not like fax machines, and we don't like when people call into the call center, because what that does is it delays care. When you go through our portal, you get in almost more than 50%. Once all the information is uploaded into the portal, there is a decision that is rendered almost immediately. We can certainly do better when it comes to prior authorization, as far as electronic prior authorization. But somebody did a survey, I think it was AHIP, and I believe it was about 60% of all prior authorizations are still submitted via fax. We need to get away from that, because that reduces turnaround time. We need to get prior authorization in line with 2023 and get it done in an electronic portal, because a portal at the end of the day will render the decision much more quickly and efficiently than any fax machine. So those are just some examples where we absolutely have some solutions, and would welcome working with the proponents and other organizations, other stakeholders to craft the bill. There are other states that have done meaningful legislation. Illinois has passed some prior authorization reform. Michigan has as well. There are other states as well that we're happy to come to the table with some more solutions as well. Thank you.
All right, Representative Blue.
Thank you, Mr. Chair. You mentioned, and I don't see it in your testimony, but you mentioned about wasteful medical spending. It was a couple $2 billion. What was that total you said?
Yes. So the Journal of the American Medical Association estimated that wasteful healthcare spending is $935 billion on an annual basis.
Okay, thank you. And then the second question I have is, it's been obviously noted that other states have passed similar legislation or something dealing with this issue. In those other states, are healthcare costs higher? Does it make a difference at all? And is it different for the patient on healthcare costs on their end?
Yeah, that's a really good question, and I don't have any hard data to present. I know when I mentioned states like Illinois and Michigan, for example, we were able to reduce the turnaround times. We were able to get items like continuity and care. I would certainly argue that that has benefited the patient, right? And has alleviated some of the concerns of what you heard in the proponent testimony. Do I have any data I could present to you? I can certainly look into that. I don't. But we were very proud of working with the sponsor in those particular states and some of the proponents as well of those bills of prior authorization reform. So I can certainly put that as a note to get back to you. It's one I would like to know as well. But thank you for that question.
All right, Representative Dodson.
Okay. My questions will be pretty short, so hopefully your answers can be short. You stated at the beginning that doctors are unable to keep up with the pace of change. So I'm wondering how a company comprised mostly of administrators can keep up with that same technical data better than the doctors.
Yes, sir. So we have, as I mentioned, we have a staff of about 400 board-certified physicians. It's about a third of our administrative staff. And their whole job is to make sure that the request that is being ordered is in line with the latest evidence-based medicine. So there are, in fact, physicians that are constantly looking at this and evaluating for appropriateness.
Okay, the second one is when I talk to physicians, and unfortunately I've had to talk to a lot of physicians over my lifetime, most of the time they tell me that they have to go through procedures simply because that's what's required by the insurance companies. Some of the times it's required by their own medical insurance. That is, well, I won't go into my own personal experience with my wife, but just suffice it to say, their belief is many of those processes are caused by insurance companies, not by things they desire. They want to get right to the solution that they have in mind.
Absolutely, yes, sir. We would certainly agree with that. I think that's why if you look as far as turnaround times, getting to the solution, right? From an Evercore perspective, although we are not the only benefit manager, we certainly are the largest. Again, I mentioned 100,000 cases that we adjudicate every single day. Across the board, 98% of those are adjudicated within 3 business days. So getting to a solution is certainly something that we agree. We want to make sure that the patient at the end of the day is getting the appropriate medical care that they need.
And lastly, this is a little bit like what I experienced in the military, but the insurance company is remote, and what they're dealing with is something on a piece of paper. The doctor is dealing with a patient right there in front of him and sees everything. I see quite a dichotomy in a decision-making process based on that.
Yes, sir. So just to address that, right? Again, as I mentioned earlier in my testimony, it's just, if you flash back to the 1950s, versus today, the pace of change is just incredible. And it's unfortunate, and it's just the reality in this day and age, the doctors aren't able to keep up with that. And so that's why our 400 doctors are on staff, making sure that we're partnering with the physician. We know there is a patient at the end of the day. We certainly don't want to stand in between the ordering physician, your provider. We want to make sure that we're partnering with them to make sure that the order is in line, again, with the constant evolution of evidence-based medicine.
Thank you very much. I appreciate it. Thanks, Mr. Chair.
All right, Representative Proctor.
Thank you, Mr. Chair. So that number, $900 billion, is pretty incredible. Who's paying that? How much of that is being borne by insurance companies, and how much of that's being borne by patients?
Yeah, it's a good question. And I don't know if I really have the expertise to really answer that. I know there are others behind me that might be in a better position to answer that question. So I'll hopefully defer to them and hope that they can answer that question. It's a good one.
All right, Representative Bergquist.
Thank you, Mr. Chair. Sir, thank you for your testimony. You mentioned a certain number of 400 board-certified physicians, and is that a correct number? And who is that? Does that represent across the whole country?
So I'm speaking only on behalf of Evercore, right?
Okay, your organization. Okay.
My organization, yes. So
okay.
We have our board-certified physicians are scattered all throughout the country. We have various different offices around the country. A lot of our physicians work from home. Some of them work in the office, but all of them, again, are medical doctors or experts in their specialty. Physical therapists, for example.
Just a couple of brief questions then to follow up. What percentage of, would you say, of the decisions that are made for authorizations directly involve those 400 physicians, and how many relate to checking a code or another device in order to make a decision?
Yes, sir. That's a good question, and I might ask Dr. Shrania to jump in if I need to. She needs to expand on this. So, by law, denials can only be issued by a physician, right? So, if Evercore sees this request and it does not meet the evidence-based criteria, a doctor, an MD, I believe it's an MD, has to sign off on the denial. What I haven't mentioned, so with 400 doctors, we also have about 800 registered RNs on staff. So when you add all clinicians together, it's about 1,200. And so we have a process by which, an efficient process by which, if we can't, we call it getting to yes faster. So if a request comes in, it will be processed in such a way that usually our RNs will look at the case. If it's more complex, it goes to our doctors, and then there's some dialogue back and forth, and including a peer-to-peer as needed, and then a decision is rendered. Now there are some algorithms that are used on the intake process. So when you submit a case, there are a series of questions that are asked. Sometimes based on the questions that we get, that request can be electronically approved right away, right then and there, within 60 seconds. But when cases where the review of the medical, the presentation of the medical criteria, of the medical folder needs a little bit more scrutiny, then that will go to our doctors and ultimately our nurses. And at some point over the course of a couple of business days, just a couple of business days, a decision is rendered, either an approval or denial. A nurse can always make an approval, but can never make a denial.
All right, and just simply to the point, are most authorizations done without the assistance of one of those physicians? The authorizations, not the denials, the authorizations.
Yeah, I think that's a good question. I don't have the data on that. Evercore is increasingly working to be more efficient. And so where we can say yes much faster, and if it can be done through an electronic process, whereby the ordering physician calls in or somebody in the office calls in, presents that information, we try to spit out the authorization right then and there. As far as a percentage, I can certainly get that to you. I just don't have that here with me, but it is a fairly high number. That's one of the reasons why we can get to yes.
I appreciate your candidacy. Thank you, Mr. Chair.
All right, Representative Haskins.
This is, thank you, Mr. Chair. This is just for clarification. We make reference to 24 hours is tight, even though we have, I think you said 1,800 waiting medical professionals, and medical knowledge has increased 73 days since 2020. Seems like we've gotten pretty good at a lot of things. So with that, though, that's 24 hours is impossible. The bill also covers 14 other timelines, and so the 24 hours is only for emergency care. I'm trying to find out what the issue is that you have with it other than the gold card, because the bill does give different timelines.
Yes, sir, it does, and that 24 hours was the emergency. Well, let me clarify some things. So Evercore does not do prior authorization for emergencies. These are non-emergent outpatient settings. So somebody falls and hurts their knee and there's an MRI that needs to be requested. There's no emergency room involved here. What I meant by that, and somebody asked earlier about solutions. We certainly think there's an opportunity here to reduce turnaround times. But let me just give you an example. I have to go back into the bill, but say it's one business day. And I don't know if that's in the exact language, or one calendar day. So say a physician submits a prior authorization request on Friday at 5 p.m. Well, if it's one calendar day or 24 hours or whatever it may be, that means a decision has to be rendered by Saturday at 5 p.m. Most physicians' offices, the ones that we work with, are not in on the weekends because these are not for emergencies. And so what that does
I'm
is
sorry,
that
just
causes
to interrupt, if I may.
Yes, sir.
I'm sorry, it's just.
Representative, normally I would call on you to speak on that one.
I apologize. No, let's go ahead.
Go ahead if you want to round out your
Nope,
question.
it's fine. Thank you very much. Nope, I apologize to the committee.
All right, did you have more to add to the question or to your answer, I mean? No, okay, all right, very good. Are there any further questions for Matthew Ness? Seeing none. Okay, very good. Thank you for being here.
Thank you for your time.
All right, next up we have all live performance, which is always a little easier to handle. All right, first up, Jonathan Buxton, Senior Director for Pharmaceutical Care Management Association. Senior Director of State Affairs, that is. Welcome to committee.
Thank you, Mr. Chair, members of the committee. My name is Jonathan Buxton. I represent the Pharmaceutical Care Management Association. We are the national association that represents pharmacy benefit companies. Out of mercy to the committee, I will not rehash or reread my submitted testimony. But I will say a real quick summary. From the perspective of our member companies, prior authorization is truly about a partnership. We are partnering with providers to make sure that the best care is provided to the patient at the right time for the right diagnosis. It's important to recognize that it is not just the patients and the providers that are involved in the situation. We are talking about payers as well. Insurance is a pooling of risk. We all pitch in We all pay a share, and then we all take care of our neighbors. Because of that pooling of the risk, it's important that payors have some say in how things proceed to make sure that doctors and hospitals are providing the most efficient care, the lowest cost care that will work to treat that patient. Much like all of us do with a sick kid, first we try, a cold rag and chicken noodle soup before we jump to a x-ray for a chest cough. Prior authorization is that stepping. It's the use of medical-based evidence to provide the best care. And as it's been mentioned before, medical knowledge is growing exponentially. Every 73 days, it doubles. Prior authorization is the opportunity to bring in a second opinion to help make sure that the most current data is being used to treat that patient. It saves when it comes to cost, making sure that we're doing the lowest cost, most effective treatment first just makes good sense. And it protects those payers, the health insurance companies that are being, it protects the plan sponsors, employers, unions, the state, Medicaid programs. Y'all are payers, and you have to make sure that you use those resources wisely. And that's one of the reasons that prior authorization is a tool.
I apologize for that. We normally have a little more respect for the folks testifying. Go ahead.
That's all right. I spent the long weekend with the kids, so I'm used to distractions. And finally, patient safety. Bringing multiple heads into one situation to look at the whole perspective. Our member companies know every drug that is filled on the patient's plan. A physician may not be aware of everything that's been written by another doctor if they're in a different network or if they're in a different hospital system. Prior authorization allows us to protect patients by making sure that adverse drug interactions are caught, making sure that drugs that are subject to high potential for abuse are monitored. Prior authorization is a partnership. Working together over the summer, we can partner with these providers to figure out some solutions that will address their concerns. And we look forward to that opportunity, and I will let you have your time. Thank you, sir. Oh, questions?
Can't dodge out on that. All right, committee, Representative Proctor.
So I'll ask you the same question I asked the previous conferee. Do you have any sense, if the number's really 900 billion and waste and medical procedures, how much of that's being borne by the payers and how much that's being borne by, the state? Because we're not have folks who are uninsured.
Absolutely. I can speak anecdotally on that. I spent 10 years working in a doctor's office doing prior authorizations. If a procedure was not authorized and we could not fix it with supplemental data or documentation, one of three groups ends up bearing the cost. Most likely, it's the patient. If it's not a covered benefit, they're on the hook for it. Oftentimes, patients couldn't afford it, so the doctor took the hit and had to write it off as bad debt. If it's unnecessary care that is approved or that is paid by or covered by the insurance company, the employers are paying for that. So your Medicaid program's paying for that, your health benefit plan's paying for that, and every employer's health benefit plan is paying for that. So one of those three people is going to be left carrying the bag.
All right, Representative Woodard.
Thank you, Mr. Chair. Thanks for your testimony. You mentioned protecting patients jumping to an x-ray for a chest cough and comparing a doctor to a mom providing soup. To me, that is you just proving the point of the proponents, that you believe insurers are better at practicing medicine than our providers are.
So our utilization management programs are developed by physicians and nurses and practicing folks. We don't make it up whole cloth. Those, for PBMs, we use pharmacy and therapeutic committees, which are independent providers, doctors, nurses, pharmacists, who develop the protocol for determining what utilization management looks like. So it is doctors telling doctors what the most recent evidence-based medicine reflects.
I want a second opinion. I'm going to go to another doctor, not my, my pharmacist benefit manager, but thank you. Thank you, Mr. Chair.
All right, committee, further questions? That was easy.
Thank you all very much.
Thank you for being here. All right, next up we have Andrew Weens, Executive Director, Kansas Employers for Affordable Health Care. Welcome to committee.
Thank you, Chairman Sutton, members of the committee. Would have brought dinner with me if I would have known we were going to go this long, so appreciate you. You all deserve hazard pay. Today, I am representing Kansas Employers for Affordable Health Care as their Executive Director, and we're standing in opposition to House Bill 2283. So if you'll allow me just a brief background, KIA is a new organization that we've launched to fight alongside businesses and employees who are facing the rising cost of health care. This committee knows how important employer-sponsored health care benefits are, not only to employers, but also to Kansas workers. And over the years, employer-sponsored health coverage has taken some hits from mandates and other government requirements that raise those costs. We think health care benefits are an important employee retention and attraction tool, and we should do what we can to keep costs low. I think if you sat here over the last couple hours and thought our healthcare system was perfect, we're probably not listening to the same folks, right? I don't think I'm here today to say the healthcare system is perfect, but if you ask employers, they would probably tell you one of the biggest problems is costs and high costs. And so we've formed KIA to push back on some things that we think drive health insurance to be more expensive. So that's the reason we're opposing House Bill 2283 today, is because we believe it will raise the cost of employer-sponsored health care. I'll also note that I believe the Kansas Chamber has submitted written testimony in opposition, so it's clearly an important issue for the business community. Healthcare benefits are something that they care about, not only for their business and what it costs them, but also for their employees and what it costs them and their families and their family budgets. So I don't think I'll belabor the points on the specifics of the bill related to gold carding and some of the timelines. I think just in general, we would urge you to consider that this is essentially the government coming in and telling private entities, how they should be conducting business and the contractual arrangements that are made between them. And we think the effect of that will be to raise cost on employer-sponsored health care. So that's the reason we're opposed. I think this adds regulations onto a process that, even by the proponent's own admission, a process that's a cost control measure that is effective at keeping healthcare costs lower. I think a couple people said something to that effect earlier. So clearly healthcare is not for the faint of heart. It's a complicated process, but there's no such thing as a free lunch. And that's a metaphor you've heard before. It's more complicated than that, but it's difficult. Someone has to pay for healthcare at the end of the day. Cost increases often fall back on employers and their employees and family budgets. So we would urge you to consider this bill in light of that fact that someone has to pay for these things. We obviously want good care for employees and for patients, but someone has to pay for it. So we want to make sure it's the right service at the right time. So with that in mind, I'll just summarize and say prior authorization is a tool that helps improve patient access to more affordable, safe healthcare services while minimizing overall medical costs. I do think, in light of some of the questions that have been asked previously about being solutions-oriented, I'm sure folks in the room would be happy to get together afterwards and talk about ways to improve. I think some of the prior opponent conferees even mentioned that. So I think I'll leave it there and stand for questions. So ask that you refrain from passing HB 2283, but open to take your questions.
All right, Representative Proctor.
Thank you, Mr. Chair. Do you, this might be an unfair question, but I'm asking anyways, do you have a sense for what's going up faster, insurance premiums or healthcare costs?
Boy, that is a good question, and I hate to speculate. It's all going up, right? I mean, you talk to employers, and it's a very tough thing that they have to deal with. I mean, you hear other things from employers, workforce issues, but healthcare is usually one of the top 2 or 3 things that employers mention. And there's a variety of ways to offer, healthcare coverage to your employees. You can have kind of a fully insured plan or a self-funded plan, and there's different levels of risk and cost that go along with both of those. And as mentioned previously, Congress is looking at some of these things, and so we're kind of doing our best to try to push back on things that we think would raise those costs.
So I know the answer, and the answer is that the healthcare costs are going up faster than the insurance premiums, and the customer in the middle is getting stuck with bigger deductibles because there's only so much that businesses can pay for insurance, and the rest is getting dumped on the patient. Thank you, Mr. Chair.
All right, further questions for Mr. Weens? Seeing none. All right, thank you for being here. Committee, we are getting through this. Next up, I have Alexander Summer, from the Government Affairs. He's the Government Affairs Principal for Prime Therapeutics. Welcome to committee.
All right, thank you all. I'm sure this is the best happy hour anybody else has had in the last few days. Exactly what you guys expected to be at 5:30 is looking at me talking right now. So anyways, I'm Alex Summer from Prime Therapeutics. We're a pharmacy benefit manager owned by 19 not-for-profit Blue Cross and Blue Shield health plans, including Blue Cross and Blue Shield of Kansas. Now, one thing we do agree on with the opponents is that prior authorization is a valuable tool. This bill takes aim at that, and that's why we oppose it. Prior authorization is one of the foundational tools that healthcare payers use to help patients get the right medication at the right time to best treat their condition. One of the things we heard about earlier and throughout testimony today is about turnaround times and the lack of efficiency and people left waiting. Notably, our average turnaround time for standard prior authorization requests is 15.77 hours, and for urgent requests, it's 3.8 hours. Whatever stories and surveys you may hear about, these turnaround times represent the reality. Prior authorization is not an administrative tool meant to frustrate. It's a key checkpoint in the healthcare system that ensures healthcare dollars are being spent on high-quality clinical treatments based on peer-reviewed science rather than inappropriately prescribed opioids or unproven, unsafe, and unnecessary hacks of the system recommended by dancing doctors on TikTok. Let's start by talking about opioids. Prior authorization is one of the primary tools used to combat the kind of opioid abuses that decimated households across the state. It is, in fact, a necessary component of ensuring that opioids are at the quantity prescribed, a necessary part of that person's treatment regimen. The gold carding scheme established by this bill removes that protection. One more example, Ozempic, diabetes drug. Used to treat diabetes is now being pushed by people on social media as a weight loss drug. You're getting people coming in and now getting drugs prescribed that are for diabetes treatment for off-label uses for weight loss. That getting pushed through, eliminating prior authorization on that drug, all of a sudden that means that you're paying for somebody else's, or somebody to get that diabetes drug to lose a few pounds. That's not what that drug is for, and that's why prior authorization exists, or one of the key reasons prior authorization exists, is to make sure that that drug is being prescribed for the right reason, the right clinical treatment, and for the right patient at the right time. Something that was noted earlier by Signet, and I think I'll just kind of reiterate, is that the requirements in this bill is that a physician would have had 90% of prior authorization requests approved, and that's the gold carding part of this bill. This still means, again, 1 out of every 10 requests would have been denied for entirely valid clinical reasons, and those requests moving forward will no longer be subject to any scrutiny whatsoever. They're going to be deemed approved. That gets rid of that check in the system to ensure that the right treatment is prescribed for the right patient at the right time. Now, like a well-functioning government, the healthcare system requires certain checks and balances. This bill takes aim at one of those fundamental checkpoints, putting patients at risk and dramatically increasing the cost of providing healthcare benefits in Kansas. For these reasons, we oppose House Bill 2283. I'll stand for any questions.
Right, committee.
Nothing?
Come
on.
You even brought up TikTok, and nobody said a peep.
Thought I might get you guys with that one. at least.
Representative Penn.
Absolutely, and thank you, Mr. Chairman, for recognizing me. I appreciate your presentation, Mr. Sommer. I've not been on TikTok. We actually passed a bill about that here in this room, right? Yeah, there you go. But I was just kind of curious, what are you seeing on TikTok? You just piqued my curiosity. How many docs are out there, and what are they talking about?
I personally don't go on it, but it's one of those things we see in, like, whether it's TikTok or just the social media sphere generally, is that people holding themselves out as healthcare professionals and pushing, this off-label use of something. And Ozempic is just one example of, it's a drug for diabetes, and they're saying it can help you lose weight. That might be one of the things that actually is that is a result of taking Ozempic, but that's not what it's prescribed for. It's used to treat diabetes, and yet these people are kind of pushing this, taking it for that weight loss side effect.
Representative Collins, that got people moving.
There we go.
Very good.
Thank you, Mr. Chair. And it just piqued my interest when you said Ozempic, because I take that not for weight loss, but isn't there a similar drug now that is on-label use for weight loss? And if so, would the company redirect someone, say, hey, maybe you should be taking this instead?
I can't speak to what the criteria might be or what they might refer somebody to. If they were in need of that medication, if they had if they were indicated for that product, then they might be referred to it. But as far as somebody that's just saying, I want to lose 10 pounds and can you prescribe me something, they wouldn't be necessarily referred to that. It's going to be based again on that patient's profile. So I can't really speak to specific medications, patients, all that.
Okay, well, I used that as an example, but
Yeah, it's fair, yeah.
the other drug, but you did pretty much answer that. Thank you.
Yeah, thank you.
All right, I see no other questions? So other than weight loss, you've got it all covered, man.
Thank you for your time.
Thank you. All right, last but certainly not least, we have Sonny Mickle, Vice President of Government and Community Relations at Blue Cross Blue Shield of Kansas. Welcome to committee. You're batting cleanup, so make it count.
Well, thank you, and good evening, everyone. Didn't realize we were going to stay this late, but I do appreciate the extra time to allow us to explain our views on this bill. So just again, I'm Sonny Mickle. I'm the Vice President of Government and Community Relations at Blue Cross Blue Shield of Kansas, and it's a local company. We're a mutual company. We're not a for-profit company. I want to make that clear. So when we are talking about issues, there are issues that are important to our members because we are spending our members' dollars on their health care services. We also operate here in 103 of the 105 counties. So I want to point you to testimony that's in your packet from Blue Cross Blue Shield of Kansas City. They cover Wyandotte and Johnson County. They provide a written testimony. But when I'm talking about things here, this is really important to us. I can tell you that I typically do not come around the legislature very often. Some of you probably haven't seen me before. Others know that I only come in a few times a year. And we try really hard not to ever oppose legislation. It's our goal to try to work with providers because providers are the backbone of what we do at Blue Cross Blue Shield of Kansas. And we value what they do in the communities, and we understand that they are practicing medicine, and that's what they should be doing for our members and for Kansans. But when I am speaking about a bill, it's because it's something that we do think is so important. And in this case, House Bill 2283 is not the bill that should be passed for us. And I know there was a question about solutions and what we should do to this prior authorization problem. And I really want to make sure that we as a state are looking at our current laws that are on the books today. We actually have utilization review laws here in Kansas that have been passed, and those utilization review laws are actually based on the Department of Labor, U.S. Department of Labor standards, and those are actually using the Utilization Review Utilization Review Accreditation Commission guidelines. In those guidelines, those laws actually allow the state insurance commissioner to set regulations on prior authorization. And our insurance commissioner has done that today. It includes many of the timelines that are listed here in House Bill 2283, in addition to more information. What House Bill 2283 does is actually conflicts with current state law, and it also makes it more challenging for us when we're trying to work well with our providers and communicate with them about the opportunities we have to provide coverage for their members and their patients. I'm also concerned because there seems to be a lot of confusion about what we can and can't do right now in the state. And that means then we need to do more with communicating how the prior authorization laws actually do work in Kansas today. I can tell you at Blue Cross Blue Shield of Kansas, we actually have many resources and provider relations staff that spend their time traveling around the state, meeting face-to-face with hospitals, face-to-face with clinicians, and actually all the provider offices. And last year, we actually had more than 3,400 in-person visits around the state with providers. The troubling thing is, though, that this issue did not come up when we were actually meeting with those providers. And that bothers me, and I want to make sure we have that open door policy, and if they have complaints, they bring them to us, because each situation could be unique. There could truly be a problem, and we want to make sure that we are following the laws in the state and providing our members with the coverage that they are purchasing from us. I also want to point out, we talked a little bit before, and we heard Alex Summer talk about the diabetes drug, Ozempic, and the problems there. And I can tell you we're seeing the same situation, and when prior authorization is used in those medications, it's to make sure that our members are also getting access to medications they need. We get calls every single day from providers and members saying they're having trouble sourcing some of those needed diabetes drugs. And it's because they're being overused in the wrong way. And that's important to us too. So when we have prior authorizations in place, it's also to make sure that the medications are going to the people that need them the most. I know there's some concern about emergency services, and that was brought up in this legislation, and I can tell you state law today prohibits anyone from having prior authorizations on emergency services. So if that is happening, again, we need to talk more about that, and that's something we want to sit down and hear those examples. Actually, I know there's talk about having statistical reports. We want those statistical reports. We want actual evidence, and we want to go through those examples so we can make sure that we are enforcing the policies and procedures that are already currently in state law. I also want to point out something that people haven't really talked a lot about today, and that's with opioid drug use. This is not in my written testimony, but it's something else that popped up, back in the day when we were, just basically handing out opioids like candy. Then insurance companies came in to try to help stop the opioid epidemic. And they put prior authorizations on those medications to make sure that they were not the first line medication going out the door to someone coming in when they were seeking pain medication. If we had not put prior authorization in place in those situations, the opioid epidemic would be worse than it actually is today. So there are some valuable tools with prior authorization, and those are just examples that I want to make clear to all of you. The last thing I want to leave you with is that we're not taking this lightly. We do think it's important that we actually sit down and talk about this more. And it's really important that we, again, bring those facts together. But I want to make sure that you understand that we are taking this serious. Because if people are not getting the care they need and they deserve that's covered under their policies, it's not good for anyone here in Kansas. And I can't move to another state or go somewhere else. This is where we operate and do business for our members. So I do care about what is being brought up today, and I really do hope that you have questions for me and I can answer them, and that I also have the opportunity to work with the provider community because they are so important to us. Thank you.
Excellent. Thank you for being here. Committee, questions? Representative Blue.
Thank you, Mr. Chair. Sunny, is Blue Cross Blue Shield in all 50 states?
We are, and also other countries. We have different plans in different states, but the state laws in Kansas are very clear, so we are following the laws here in Kansas.
The next question I have is, it's been brought up that other states have a prior authorization legislation already in effect, and just curious on, do you have issues in those states where, I think Indiana was brought up, I don't remember what states. It's been a long afternoon. Yes. So I'm just kind of curious on your end with being in all 50 states, and this is maybe something you can come back to us on. Do you have issues in those states?
Well, I can tell you that each individual Blue plan is an individual licensee of the Blue Cross Blue Shield Association. So I do not personally, our company does not personally operate in these other states. I can tell you that I'm aware that the only time this type of legislation has been passed on prior authorization is in Texas. And from my understanding and talking to others in the insurance industry, it's very hard to work with this legislation because it does conflict with the laws that we already have in place. So I do think other states have other laws, but some of them are farther behind what our law does today. And we actually have the same timelines and standards, and in many cases even better. For example, I'm sorry to take so long, but peer-to-peer review is brought up, and something that people were saying is not being covered. That actually is required today under state law. So again, and our state law requires that to happen in 1 business day. The way this legislation is written, it says 2 business days or 48 hours. So we actually have a much stricter standard than what's even being proposed. So every state is different, and I would have to actually look at each individual state law to see, what may be better or similar to Kansas.
Thank you. And if I could have a follow-up to research. Could I request what the insurance commissioner has dealing, Sunny, this is the first time I've heard of that, our insurance commissioner has dealing with this. And so could I get that from research? And the second question is, could research do a comparison on some of the states that have passed prior authorization laws and just kind of compare to what they've passed compared to what we have in front of us?
All right, Representative Haskins.
Thank you, Mr. Chair. Thank you for your testimony. And My question is I have constituents that will contact me and will disagree and say that prior authorization has slowed down them getting regular medicine on a typical, practical, rational basis. And so my question is there a problem with prior authorization? Are my constituents just mistaken, or do they just have the wrong insurance company and it's just a couple bad apples that are ruining this?
I think it's a mixture of everything. I can tell you that Blue Cross and Blue Shield of Kansas, 75% of the prior authorization requests that we receive are not required. They're being submitted voluntarily by providers. So they do not have to send those in. They send those in addition to the 25% that are required. So you can imagine that kind of creates a work situation. And then on top of that, I can give you an example during COVID-19, the height of COVID-19. We heard from providers then, so I do want to make that clear. Providers and hospitals came to us then and said, we can't do this extra work. We have all hands on deck. We actually waived prior authorizations during the height of COVID-19 in 2020 and 2021, so for 2 years. And we actually still kept receiving prior authorizations from all the hospitals and providers. So I don't know what they're communicating to those patients of theirs, but in that situation, we were not putting a prior auth in place, but they were still sending them in to us.
Well, and thank you for that. And it's just a matter of, I think everybody's in agreement that prior authorization has a purpose. I mean, no one's denying that. And I appreciate you saying, hey, let's get together and work on this. I think that's noble. So what would be, how could we make this work? What would be, what would you negotiate on if we're going to work on this bill? What's in here that's good for our constituents? Because I'm going to have a couple calls when I get home to make.
Sure. I think what's in here that's good is what's consistent with state law today. Again, there's some misrepresentations, and I think there's just confusion because it's hard to kind of read through those regulations. I'm not blaming anyone for doing this. This is what I do for a living. So I even have to sit there and dig through them and look at them and read them and actually then talk to the accrediting entities. So we actually have accrediting entities that oversee the insurance companies, and you can't operate if you don't actually get accredited. They come and actually do desk reviews to make sure that we are following through and how we actually practice these procedures. So I think going through and making sure that the things that are outlined today in state law are happening must be done. And that's part of this legislation. But there's no need to have legislation on top of current state law in those situations.
Right. Representative Penn.
Thank you, Mr. Chairman. I have one question for you, Ms. Mickle, and then I think I have one, Mr. Chairman, maybe for the revised, I'm not sure. On the heels of, and Rep. Haskins was taking my question pretty much, okay? Have you called a summit of all the players and key stakeholders in this space, maybe build out a schedule where you put them all together into a room and let's go through exactly what is best practices, not only what our current law is, but as you've been speaking on, but also what are we seeing, as Rep. Blue asked, what's going on in other states and other regions so that we can actually get to the bottom of this and pull everybody to the same understanding of what the landscape looks like by pointing the fingers each way. What would that look like? Have y'all ever done that? Is that something that you'd be interested in doing, setting up that schedule so that when we come back in here, we can actually get something done?
We'd be happy to do that. We currently today, we do something separately at our company. We don't typically sit down with the other insurance companies. That would be antitrust in some situations. But what we typically do is we actually go out and we have hospital forums. During COVID-19, those were not actually happening in person. But what we were doing still is having our reps go around individually to offices. But the hospital forums that we conduct across the state actually allow us all to sit down together and have a mutual agenda. We talk about things and they should bring issues forward. So I think that's an opportunity of something similar to that. That's worked very well for us. We do it by region because it may be also different regions of the state are experiencing something different than your urban centers. We often find in rural communities things are happening differently. Or again, it's just a need for us to all go through and educate each other on what's actually happening.
Absolutely. Thank you for that, Mr. Chairman, if I may. The other question I had was dealing with the fiscal note. Who would handle that? Okay.
think
Melissa would. Okay, okay. Let's see, want to talk about the fiscal note. When they did that, if you could let the committee know, what did they take into account? Did they take into account the state employee plan when they devised that, the Medicaid costs, cost to cities, cost to counties, school districts, those types of things as well?
Comment on that. A zero fiscal note seems a little pie in the sky for legislation such as this.
Mr. Chairman, Vice Chair Penn, it appears the parties contacted for the fiscal note include the Insurance Department, the Board of Pharmacy, the Board of Healing Arts, and the Judicial Branch. And so those are the individuals who've provided those costs. It does not appear that it speaks to local governments or employers, either as a state plan or any other plan, a local health plan.
Mr. Chairman, I would rejoin you. That seems a little incomplete. Thank you, Melissa, for that. I would recommend that we actually get that fleshed out a little bit more, please.
Understood and concur. Representative Neighbor.
Thank you, Mr. Chair. I know you're talking about Blue Cross bringing people together, but I think this is more than a Blue Cross. It's a Cigna. It's a United Healthcare. It's all of the larger entities. We need to have one consistent set of guidelines and understanding. So if and when there is a meeting, it needs to be all-inclusive, not with just one insurance company. It has to be everyone come and make those agreements so that everybody's on board, because every insurance company affects every one of these people, not just Blue Cross Blue Shield of Kansas. So I would ask that whatever meeting is held is all-inclusive so we can reach a common denominator, a common outcome that suits everybody as much as possible. Thank you.
That. Thank you.
All right, and when we have that meeting, we're going to give, first off, we're going to start early in the morning and give everyone Nerf bats. I wasn't even paying attention to what I said. It's 6 o'clock, for crying out loud. All right, do we have any further questions for Sunny? Oh, steel cage. I like that. All right. Seeing none, thank you for being here and thank you for your testimony. Committee, I see no one else scheduled to speak as an opponent to whatever bill we were just discussing, 2283. I put it away already. Give me a break. All right. Is there anyone here who would like to speak as an opponent to 2283? Seeing none, I will close opponent testimony, close the hearing on 2283. Committee, remember all those days we got out in half an hour because I misjudged the amount of time it was going to take? I did it again, only it was the other way this time. You're forgiven. I also misjudged the amount of time this hearing was going to take, or else I would have scheduled it for 2 days. Yes, Representative Penn.
Thank you, Mr. Chairman. Before we get ready, it feels like we're about to land this plane. I would like to see Representatives Essex, Collins, and Howerton right after, please.
You guys are in trouble. The rest of us are going home. All right. With that, ladies and gentlemen, we don't have another meeting scheduled this week. We will be on the floor, and then we'll be at turnaround. So keep an eye out. We will be meeting again. I've already seen some of the Senate bills that have come over, and they look very suspiciously similar to ones that we already passed out of here under a House bill. Yeah. But until that time, we are adjourned.